I'm Gabby. I'm going to be talking about initiating BiPAP. So we're going to answer a couple of questions today. First of all, what is BiPAP? Who can benefit from it? When should I skip it? Where do I start if I do decide to use it? And is it working? So BiPAP, or bi-level positive airway pressure, is a non-invasive method of non-invasive ventilation. It augments spontaneous respirations by basically providing two levels of positive pressure, EPAP, which is just like a baseline level of pressure, and then IPAP, which is during inspiration. Then there's the difference between the two of them, or the change in pressure during respiration, called the driving pressure. And the driving pressure will help bring in tidal volumes. Let's see. So it's important to keep in mind that this is patient-driven. So you're not going to have basically the patient's drive is what's going to determine your tidal volumes and your respiratory rate. And then you're only going to be setting the IPAP and EPAP. So what does BiPAP do? It basically reduces your work of breathing by increasing pulmonary compliance and recruiting alveoli. And then it also improves oxygenation and decreases hypercapnia by increasing your tidal volumes and minute ventilation. So basically, in summary, it stents your airway open and improves gas exchange. Okay, so when can we use BiPAP? So I'm basically going to talk about the more common things that we use it for and the ones that have more evidence behind them. There's other things, but they're not used as often, and there isn't as much literature. So one of them is acute pulmonary edema. Basically, you have an oxygenation problem, and the positive pressure is going to help you push fluid back into the vasculature, and then it's also going to increase the intrathoracic pressure and hydrostatic pressure. The increased intrathoracic pressure is going to decrease venous return to the heart, and it's going to decrease your preload and afterload, and then so that can help your cardiac function by reducing the amount of stretch in the heart muscle, and then that way it can better contract. Okay. Another setting in which we can use it is COPD and asthma. Here, basically, we have airway narrowing and air trapping, and this leads to a ventilation problem. So here, the driving pressure that we talked about, the difference between IPAP and EPAP, is going to help decrease your work of breathing, improving ventilation, decreasing your CO2 level, and improving acidosis. Also, the positive expiratory pressure is also going to help you stent the airway open and prevent hyperinflation and air trapping. Something you do have to look out for is the tidal volumes, because this can lead to barotrauma. Okay, and something that's very important to note is that for the use of BiPAP in asthma, there actually isn't a great amount of evidence. There is some compelling evidence, and it's used because we're really trying to avoid intubating these patients, but it's not the evidence is not as solid as it is for pulmonary edema and COPD. Okay. So when should we skip BiPAP? When is this not a great idea to try? Can somebody tell me some times when or reasons why it might not be great to try BiPAP? Anybody?
Small-term mental staff.
You can't get good seal.
Okay.
You can't get good seal.
Yeah.
Without facial.
Yep.
Upper airway obstruction.
Yeah.
AMS.
Yeah. All of these are good things or reasonable things.
Pneumonia.
So Here's a list of some of them. I actually wanted to talk specifically about a couple of them. One of them is altered mental status. It is true that a patient with altered mental status won't be able to cooperate. Also, like we talked about, you're depending on the patient's own respiratory drive. So if they're somnolent, they won't be able to help you there. But it's a relative contraindication because, for example, when we have somebody with hypercapnic respiratory failure, you can try the BiPAP on and see if their mental status improves, because your hope is that relatively quickly you'll blow off some of that CO2 and get an improvement in the mental status. So you can, in a case like that, it's a relative contraindication, but you have to watch them very closely. Something else is like facial trauma, because it depends a lot. Your function will depend a lot on getting a good seal, and if you don't have it, then it just won't help. Something important is inability to tolerate having the BiPAP on. There's two things I wanted to note, and one is checking if you have a good seal, because the machine is going to try to reach a set flow rate that if there's not a good seal, it'll basically, the inspiratory time will be very long and it'll be uncomfortable for the patient. So they might just not be tolerating it because of that. And then the other thing is the possibility of trying sedatives and anxiolytics. You might try things like Precedex, Haldol, ketamine, opioids, benzos. All of these have their advantages and disadvantages, but it's just something that you can try using. For example, if you can consider using something that reduces your respiratory rate, if that's something that might help your patients. Very patient dependent and situation dependent. And then the other thing is multi-organ failure. So BiPAP isn't something that you can use for a very long amount of time. It'll be very uncomfortable for the patient. So that's something that multi-organ failure isn't something that you're going to be able to fix relatively quickly. So it would probably be more appropriate to intubate the patient. So let's see. So what do I do with my settings? So let's start with talking about pulmonary edema. So you have an oxygenation problem. So you're going to want to maximize things that improve oxygenation. In this case, it would be the EPAP, sorry, and maintaining your driving pressure basically as narrow as possible. And you do this because that way you have a relatively high pressure throughout the entire respiratory cycle, which will help you offload the heart. And then the other thing is that you're getting is recruitmental alveoli to help oxygenation. And then the other thing that's important to note is that even though I'm talking about BiPAP today, CPAP also has very good results in the setting of pulmonary edema. So here we see an example of titrating your BiPAP settings. I saw a lot of examples there. None of them were particularly different. So that's why I just chose to use this one. But the basic idea is that you're increasing your EPAP, okay? And keeping your driving pressure relatively narrow and unchanged. Let's see. And then in the setting of COPD and asthma, we have uncompensated respiratory acidosis, right? So we just want to blow off CO2. So we're going to want to do this by improving ventilation, and we do this by maximizing the driving pressure and IPAP, using our IPAP. So basically, we're decreasing the work of breathing and helping our patient not tire out, and then as we do this. So something to note with increasing the pressures is that you don't want to go too high. I couldn't find a specific number that you absolutely can't go above this number. Basically, the different resources I used, there were numbers ranging between 15 and 25. So you basically just want to keep an eye out, because you want to avoid two things: paratrauma, and then the other thing you want to avoid is decreasing your preload and afterload, and decreasing your cardiac function by increasing your pressure too much. So then again, another example of titrating the settings. Here you're basically changing your IPAP to try to maximize your driving pressure. And then something also is that basically we're talking about IPAP and EPAP here mostly, but you also can always change your FiO2 as needed. So I have it on. Is it working? Is it worth continuing, or do I need to scrap it and intubate the patient? So frequent assessments are going to be key here. You're going to look at your work of breathing. Are they able to talk to you? Are they using accessory muscles? Are they tripoding? Looking at the respiratory rate, because this means they're likely to tire out. You're also looking at their mental status, because we said that mental status was a relative contraindication. So, but if it's worsening, then you definitely, it's not working for you. And then you're looking at blood pressure, heart rate, looking for any signs of hemodynamic instability. And you're also looking at your tidal volumes and minute ventilation, because if these are decreased, then it means your patient's hypoventilating, and it's just not going to be helpful. So for normal values for tidal volumes, about 6 cc's per kilogram. And then for tidal volumes, between 6 and 7 liters per minute are kind of normal. When you're looking at these, you really want to make sure, again, to have a good seal, because if not, they're not going to be accurate. And then lastly, the ABG and VBG, they can be helpful, but they're not absolutely necessary to determine if your intervention is working. There's no specific number that you're trying to target to know if it worked or not. So it's going to be more of your clinical picture as opposed to a lab value. So what have we learned today? Basically that BiPAP can help you avoid intubation, but it's not for everybody or every case. It works by improving your work of breathing, improving oxygenation, improving your respiratory mechanics and cardiac function. Then basically in terms of the settings, if you're trying to improve oxygenation, you're basically working with your EPAP and your FiO2. If you're trying to improve ventilation, you're working with your IPAP and your driving pressure. And then other major thing is reassess. And if it's not helping, don't hesitate to intubate. And one moment where also we have to remember to reassess is a lot of patients can often come with EMS, brought in by EMS, already on BiPAP or CPAP. And you want to, at that moment, reassess and see, okay, is this actually helping or not, or just intubate them when they get here. So that's basically what I have. I wanted to thank the Small Talks team, especially Dr. Chu and Dr. Beta for their feedback. That's what I have.
As you said, Gabby, it's really important to think about the etiology that you're treating, and usually you're dealing with short-term things that you're currently treating the problem, like COPD and CHF. I guess what turned that upside down on us is COVID. I don't know if anyone has any thoughts on that, but I haven't been able to consolidate that yet. COVID is a pneumonia and pneumonitis, and it seemed like non-invasive ventilation was better than invasive ventilation, which goes against the classical teaching that we have in the field.
Yeah, actually, I stayed away from COVID just
that's
because
smart.
it would have,
There's nothing really
the whole time would have been just that probably.
But it's interesting that typically a pneumonia or pneumonitis that's not improving, you would intubate that patient.
Yeah,
So
a lot of the things I've read also talked about high flow as well, and then in patients like that, then it mentioned it's better off trying high flow.
Yeah, lots of alterations on that.
And then interesting was that there were also other uses that were mentioned for BiPAP. We don't really see this as often, or at least I haven't seen it here, is neuromuscular disorders like myasthenia gravis and things like that, but there isn't as much literature out there about it. Also using it to pre-oxygenate people who are hard to ventilate before intubation. And then what else? People who are DNI, who might be willing to try BiPAP.
Stop.